Oki and welcome to the University of Lethbridge. Our university's Blackfoot name is Iniskim, meaning secret buffalo stone. The university is located in the traditional Blackfoot Confederacy territory. We honor the Blackfoot people and their traditional ways of knowing in caring for this land, as well as all Aboriginal peoples who have helped shape and continue to strengthen our university community. Having said that, now I would like to say thank you to Professor Lars again for giving me this opportunity to present in this Prentice webinar. I also want to say thank you to Jeff Bingley for providing excellent technical support for this webinar. Also, thank you to the Prentice Assistant Professor Abidi Jarmin Boko for providing analytical guidance over the last 3 years. That guidance actually helped me to carry out this advanced analysis that I have done for this paper. So thank you, Boko. So having said that, now this is a brief outline of this presentation, a background on health facility based delivery in South Asia, then summary findings of previous research, and what are the gaps in the previous studies that need to be addressed, and objectives of this study, and conceptual framework, and some theoretical considerations, and data and analytical approach, results, policy reflections, and at the end Q&A session. So as you can see in this map, South Asia is commonly known as the 8 countries like Afghanistan, Pakistan, India, Nepal, Bhutan, Bangladesh, Sri Lanka, and Maldives. These are the 8 countries known as South Asian region. Now, 1/4 of the world's 7.7 billion population live in South Asia. The South Asian countries have achieved a remarkable progress in reducing maternal mortality from 550 deaths in 1990 to 160 deaths per 100,000 live births in 2017. This is a substantial progress in preventing maternal deaths. However, still more than 50,000 women die every year in South Asia due to complications from pregnancy or childbirth. The large number of maternal deaths in South Asia has been mostly attributed to higher rates of giving birth at home. Let me give you an example with some data here. As you see here, 51% women in Afghanistan, 49% women in Bangladesh, 21% women in India, 31% women in Nepal, and 33% women in Pakistan gave birth at home, risking their own lives and the lives of their children, newborn. So studies have shown that the number of maternal deaths in South Asia could be reduced substantially, somewhere between 16% to 33%, by promoting health facility based delivery. Now, what do we mean by health facility based delivery? Let me clarify that term that I will be using throughout this presentation. Health facility based delivery indicates the births that take place in any health facility. It can be hospital, it can be clinics, or any center that provide healthcare services to mothers and children, with the assistance of doctors, nurses, skilled birth attendants. So this is called health facility based delivery. It is also widely known as institutional delivery, but throughout this presentation I will use the term that is commonly used as health facility based delivery. So as you can see in this figure, one, health facility based delivery in South Asia, you see that India has the highest percentage of women giving birth at a health facility, that is 79%. Afghanistan and Bangladesh, half of the women are giving birth at a health facility. This is slightly higher in the case of Nepal and Pakistan. About 2/3 women are giving birth at a health facility. Now, one thing I should mention that you might be thinking that in India it is much lower, much higher, but if you see the absolute figures, 21% women are giving birth at home. Now, every year 25 million children are born in India. So 20% of that 25 million children equals 5 million. That means 5 million mothers are giving birth at home each year, risking their own lives and the lives of their children. This is the case of India only. So, what we know from the previous research is that factors that influence health facility based delivery include maternal age, birth order, access to antenatal care, the checkup that mothers need during the time of pregnancy, educational attainment, socioeconomic status. These factors have been found to promote health facility based delivery, particularly those who have higher education or those who have better economic condition. They have higher rate of choosing health facility based delivery. Also, there are differences across religion and place of residence. For example, women living in urban areas, they have higher rate of using health facility based delivery. Previous research, in particular the one by Boran and colleagues, Huda et al., Ryan and colleagues, and Shahabuddin and colleagues, in their study they have found that there are some barriers to health facility based delivery in the South Asian countries. For example, traditional and familial influences, distance to the health facility from home, cost of delivery, low perceived quality of care, a fear of discrimination during facility based delivery. These are the factors that discourage women in using health centers or hospitals for giving birth. I mentioned what we know from the previous research. So, what are the gaps in the previous research that need to be addressed? One of these is less is known about the extent to which social factors influence, social factors play influential role in determining health facility based delivery in South Asian countries. Also, a limited attention has been given in previous research in evaluating the extent to which women's education interact with their household economic condition in choosing health facility based delivery in South Asian countries. And in addition, there is limited research in a multi-country setting where the role of macro level socio-economic factors related to health facility based delivery are examined. So, to address this research gap in the literature, in this research study, I aim to examine the role of social factors in promoting health facility based delivery in 5 South Asian countries: Bangladesh, India, Pakistan, Nepal, and Afghanistan. So, by social factors, I mean women's education, economic condition, their access to media, religion, and where they live. Do they live in urban areas or do they live in other areas, I mean rural areas? And to assess the extent to which the impacts of female education on promoting health facility based delivery vary across household wealth status. And to evaluate the role of macro social factors in promoting health facility based delivery. What do I mean by macro social factors? For example, women's education. What percentage of women have formal education in a country? What percentages of women have access to media in these countries? Women empowerment. Do they have high empowerment? Do they have low empowerment? And per capita health expenditure. These are the macro level social factors that I looked at their role in determining health facility based delivery in South Asian countries. Now, one thing I should mention that these 5 countries, Afghanistan, Bangladesh, India, Nepal, and Pakistan, together hosts 93% of the South Asia's 1.96 billion population. So this is the conceptual framework that I have developed for testing in this research. This is a very simplified framework, but important in the sense that we have individual predictors, factors, as well as country level factors. Now, as you can see here, the social factors, two types of factors. At individual level, I have included mother's education, mother's age at recent birth, access to media, religion, residence, place of residence, household wealth, husband's education, and antenatal checkup, A and C, the checkup that they need during pregnancy. And from country level predictors, factors, we have percent of women with higher education, percent of women with access to media, percent of women who have high empowerment, play important role in the family decision making process, and also per capita health expenditure. So these two factors influence women to choose health facility based delivery. Also, you can see that there is a direct line from social factors to the health facility based delivery. That line also indicates that in addition to these factors, there are other potential factors that could influence women in choosing health facility based delivery. We will mention those factors in a moment. Now, this framework is developed following a synthesized version of two theoretical framework. The one is Anderson's behavioral model of health service use. This model actually assumes that there are three types of factors that play important role in using in the case of use of health services. For the first one is predisposing factors, the second one is enabling factors, and third one is the need factors. Now, what does the predisposing factor mean? For the predisposing factors, for example, mother's age at birth, then birth order, religion, these are the predisposing factors. And enabling factors, access to healthcare utilization, socioeconomic conditions, and need factors, for example, complications during pregnancy. So these are the factors that play important role in choosing whether women will use the healthcare services available to that country or not. There is another theoretical framework, theory of planned behavior. So I will not read this theory in detail, but the bottom line is that individuals are more likely to use health facility for childbirth if they have positive attitudes towards using health facility. They have higher chance of using health facility if they believe that family and social pressure are favorable towards using that health facility, and if they believe that they are able to use that health facility in the sense that it's about maybe distance or it's maybe about cost that they afford this. These are the factors that determine whether women choose health facility based delivery or not. Now, drawing on these two theoretical frameworks, I have developed these conceptual frameworks for examining in this research. In addition to these previous theoretical frameworks, these theoretical frameworks that I am proposing in this research also takes into account the factors at aggregate level like per capita expenditure for health, that like women empowerment and other aggregate indicators that could play important role in determining health facility based delivery in these countries. Now, regarding the data and methods, I have used data from demographic and health surveys. For Afghanistan, I used the data from 2015 DSS demographic and health surveys. For Bangladesh, I have data from 5 waves 2004, 2007, 2011, 2014, and the most recent one 2017 and 18. For India, I have data from 2 OAFs 2005 and 6 and 2015 and 16. For Nepal, we have 2 OAFs of data 2011 and 2016. For Pakistan DSS, we have 2 OAFs 2012, 13 and 2017 and 18. So, from these 5 countries, using all these OAFs together, I have a final sample size of 134,881 women aged 15 to 49 years who have given birth within the last 5 years of the survey. So, dependent variable place of recent birth, that is, as I mentioned, that the surveys provides information on the birth within the last 5 years. So, whether the birth occurs at a health facility or at home. Now, analytical approach, I provided descriptive statistics at the beginning. Then I also carried out bivariate analysis to see the associations between the outcome variable of interest and the explanatory variables that we have in the framework. Also, I carried out multi-level logistic regression analysis. This is 2 level. We have individual level factors, level 1, and we have country level factors in level 2. So, in this case of multi-level modeling, it is assumed that the individuals are nested in the country. This is the strength of conducting this kind of advanced analysis, multi-level analysis. Now, let me present the descriptive findings. Overall, 54% women in the South Asian countries gave birth at health facilities, and overall 40% women have no education, and only 10% have had then secondary education. As you see in the graph, this women's educational attainment in South Asia, these are percentages. So, we have 2 categories of women with education and those who have without education, I mean no education. As you can see, Bangladesh has the highest percentages of women who have formal education, that is 80% among these 5 countries, and Afghanistan has the lowest percentage of women with formal education, that is 15% only. Other than that, India, Nepal and Pakistan, about 2/3 women they have formal education. Pakistan is less than half, 47%. So, there are substantial variations in the educational attainment among women in these South Asian countries. Also, I found that 40% households are defined as poor based on the household wealth index, and 62% women have access to media, whether it can be newspaper, radio or TV, and 67%, that is 2/3 women are living in rural areas. 15% girls start childbearing before they reach age 20, and 20% women they do not get any antenatal checkup during pregnancy, and only 41% women they get 4+ ANC checkup. So, this is the descriptive data that we have. Now, as you can see here, I have shown this graph at the beginning, but I brought this again to just to reinforce the fact that India has the highest percentage of women giving birth in a health facility. You can see 79% and other countries. But one thing I should mention here, that the total number of births, annual births in these 5 countries are about 36 million births in each year. And if we look into the rates of women who are giving birth at home, that one gives more than 15 million births each year that occur, I mean takes place at home, not in any health facility. So, this is an issue that needs serious attention from policy perspective. Now, let me present the bivariate findings. So, what I find is female education is significantly associated with the place of delivery. As you see in this graph, women, those who have no education, no formal education, only 38% of those women are giving birth in a health facility. But if you see those women who have higher than secondary education, the percentages of choosing health facility for birth is 90%, is much higher. So, there is a strong positive association of choosing health facility for giving birth among highly educated women. Now, regarding household wealth, I found that household wealth is significantly associated with place of delivery. Figure 4 here, you can see the percentages of health facility based delivery by household wealth, and among the poor women, only 36% women they choose health facility for giving birth, but among the rich women this percentage is 74%. So, what we see that women's education is important for promoting health facility based delivery, but at the same time better economic condition is also playing important role. Now, this is an interesting graph that I am showing here. What we have here is health facility based delivery by education also varies across household wealth. See, as you can see in this figure 5, the percentage of health facility based delivery by education and household wealth. We have poor and rich, and two types of education, those who have no education and those who have higher than secondary education. Among the poor women, those who have higher education, 69% of them choose health facility for giving birth, but among the rich women, those who have the same education, higher than secondary education, the percentage is 92%. So, this graph actually gives some kind of indication that there might be an interaction effect between women's education and their household wealth status, meaning that the impact of women's education on increasing health facility based delivery varies significantly by their household wealth status. So, I have tested this hypothesis. I will show the multivariate findings in a moment. Also, significant associations exist between place of delivery and other explanatory variables that I have included in this analysis. So, based on this bivariate analysis, now we moved on the multivariate analysis to see whether after including those control variables, what kind of impact the social factors that we have used have social impact of social factors in choosing health facility based delivery. This is the table main findings with the regression analysis multilevel logistic regression model. So, these are the odds ratios. I will not read these numbers in detail, but I just want to tell the story how I have built up the model for examining the role of social factors in promoting health facility based delivery. So, as you can see the model 1, I have 4 models in here. Model 1 is called the intercept only, is also known as empty models, because there are no explanatory variables in here. All we have here is the outcome variable of interest. Now, one important piece of information in this model, as you can see marked in yellow color, the intra-class correlation in model 1 ICC, that is 6.6, this is percentages. So, 6.6%. What does it mean? It means that the 6.6% variations in the outcome variable of interest, that is where they give birth, in this case health facility, this 6.6% of the differences in the health facility based delivery are due to the differences in the classes or groups, whatever we say, in this case countries. That means women in Afghanistan or women in India, they have different rates of giving birth at a health center. Maybe those may be due to the factors associated with the per capita health expenditure or quality of health care that they have in those countries. Now, the key message that from model 1 I want to give, that this value indicates that we need the advanced level of analysis so that we can take this variability into account. So, In model 2, I have the explanatory factors that I included. I didn't show all in here. Education, we have household wealth, access to media, religion, all other variables. In model 3, we have all explanatory factors from model 2, plus I looked at the interaction effect between women's education and household wealth. The figure that I showed, like there might be an interaction effect, meaning that to test whether impact of women's education varies significantly in selecting health facility based delivery by household wealth, that is the interaction term, and I test whether this interaction term is significant. I found that it is significantly different from 0, meaning that we need to take into account the main effects and the interaction effects. Now, in model 4, we have all variables from model 3, plus we have the variables, the aggregate variables that I mentioned, 4 variables. What percentage of women have higher education in that country? What percentages of women have access to media? This is aggregate data, not individual level. What percentage of women have like high empowerment or low empowerment? And what is the per capita health expenditure in these countries? So these 4 aggregate variables are included in model 4. So now let me move on to the one thing I should mention before moving on to the findings is that, as you can see, the value of ICC marked in yellow in model 4 is 4.7. Earlier it was 6.6. That means using these 4 predictors at aggregate level, we are able to explain some of the variability in our outcome variable of interest, variability across countries. Now, this appendix A is basically from the previous table that I showed. I want to explain the impact of education and household wealth. So what we have is the total effects, that is the main effects plus the interaction effects. So it's very easy to get this output from this data. It also gives us the p-value significant with confidence intervals. So what I find here is that 1.044 multiplied by 100, it indicates that every 1 year increase in women's education increases the likelihood of health facility delivery by 4.4% among poor women. But the rate of increase in health facility based delivery with every 1 year increase in women's education is about 3 times higher for the rich women than poor women. You can see that is 15.4% increase for 1 year increase in education. The chances increases 15% that they will choose health facility for giving birth. So these same findings I have presented in a graph. In this graph, as you can see, these blue lines here is for the poor women, those who are poor women, and then the green one on top for the rich women. You can see at the beginning with no education, 0 years of education, the differences are smaller between these 2 groups, but as their education, with increase of education, all these 3 groups of women, their chance of giving birth at a health facility increases, but the rate of increase is much higher for those who are rich. You can see that at the end, you can see the differences here between the poor and rich. To better visualize this graph, I have shown this is the same graph. I am showing 2 lines, those who are rich and poor, and you can see the differences between poor and rich in giving birth in a health facility is increases with their increasing age. So that is the interaction effect, significant interaction, as we find in this bivariate analysis, that there might be differences in the impact of education depending on whether they are rich or poor. So, and we found that significant impact. Now, regarding other findings, we found that women having access to media were 34% more likely to choose health facility delivery than those who do not have access to media. The followers of Islam, Christianity, and other religions are less likely to choose health facility based delivery than the followers of Hinduism. And women living in rural areas are also 30% less likely to choose health facility based delivery than their peers living in urban areas. And husband's education also have significant positive impact in promoting health facility based delivery in these South Asian countries. Now, let us take a look into the other predictors, aggregate predictors that we included for each country. So, from those aggregate predictors, we have women's higher education significantly contributes to promote health facility based delivery. That is 1% increase in higher than secondary education contributes to 5% increase in the chance of health facility based delivery. Women's access to media is also significantly promoting health facility based delivery. Women's higher participation in the family decision making process, that one I have defined as high empowerment, it is associated with 12% higher odds, that is the chance of health facility based delivery compared to those who have low empowerment. So, women empowerment also exerts a strong influence in promoting health facility based delivery. And regarding the fourth indicator that we have, per capita health expenditure, I found that every dollar increase in per capita health expenditure contributes to 1% increase in the chance of selecting health facility based delivery by those women in these countries. So, this is the table. You can see that with that circle, these outputs all are statistically significant, all four variables that are included at aggregate level. And one thing I should mention, that value ICC interclass correlation in model 4 is now 4.7. That means these four variables have partially explained some of the variability in the outcome variables. One thing I should mention, that the per capita health expenditure in these South Asian countries are very low. As you can see here, India have $78 per capita health expenditure in US dollar. In 2018, other countries around $50. Pakistan, they spend $43 per capita health expenditure. This is very low, and if you look into other Asian countries, Japan, obviously they have very high expenditure, $4,000. Then you have Singapore, South Korea, Maldives even around $1,000. But if you look to other South Asian countries, Sri Lanka, they have $157 per capita health expenditure, which is almost 3 times or higher than the other Afghanistan, Bangladesh, Nepal and Pakistan. Now, one thing I should mention here, that Sri Lanka, what percentages of women in Sri Lanka give birth at a health facility? It is surprising, it is 99% women in Sri Lanka give birth at a health facility. So, two things is, women in Sri Lanka are highly educated and their per capita health expenditure is also much higher than these 5 South Asian countries. So, it reinforces the fact that greater investment in healthcare is one of the key factors that can contribute to promoting health facility based delivery. Now, so what I found in this study is that women's education is significantly associated with promoting health facility based delivery in the South Asian countries. However, the impacts of women education on promoting health facility based delivery vary significantly across their economic condition. The impacts of women's education on promoting health facility based delivery is stronger among women who are living in households with better economic condition. So, these findings these findings tells us that government should emphasize more on women's education and also improving their economic condition. Now, the question is, it raises the question is, how do women's education and household wealth contributes to promote health facility based delivery in the South Asian countries? What are the underlying mechanisms? Now, based on the previous studies, it has been found that is those who are highly educated women, they have greater awareness about the risk of giving birth at a home. This is one thing. And the another thing is regarding the household wealth, I mean economic condition, those who are rich, they have greater ability, I mean they afford to use the health facilities. There are expensive, sometimes expensive, that is also actually contributing to increase the health facility based delivery, those who are highly educated and those who are rich. Now, among other factors, among other social factors, access to media, place of residence, women empowerment, per capita health expenditure are found to substantially promote health facility based delivery in South Asia. Now, regarding future research, findings of this study are consistent with earlier studies, and this study adds important insights into the interplay of both individual and country level social factors in determining health facility based delivery in the South Asian countries. Findings of this study also reveal substantial variations in health facility based delivery across countries. So, future research should include more predictors at aggregate level to better explain the variations in the health facility based delivery across countries. Like, let me show this table again here. The circle marked in red, it has like 4.8 the value of ICC. Now, it was 6.6% variability between these countries, but it has reduced to 4.7% because of including these 4 indicators. The 4 indicators explained about 2% of the variability, but the question remains is what are the factors that explain the remaining variability between these countries. So, we need more predictors, more research to explain this aspect of promoting health facility based delivery. So, policy reflection. From a policy perspective, while facilitating women's education should be considered as an important priority for promoting health facility based delivery in South Asia, equal emphasis should be given on ensuring economic empowerment of women, so that they can afford to bear the costs associated with health facility based delivery. And substantial increasing in per capita health expenditure should be considered as one of the utmost priorities of the government's initiatives for ensuring quality maternal health care services. Increasing per capita health expenditure by the government is particularly important for these South Asian countries where patients out of pocket health expenditure is more than 2/3 of their total health expenditure. So, 66% of the health expenditure are out of pocket expenditure. So, government need to address these aspects by ensuring greater investment to ensure quality healthcare services, so that women they afford this and they come to the health facilities, they choose health facilities for giving birth. Now, I would like to stop here with an acknowledgement. I want to thank the Prentice Institute for Global Population and Economy for awarding me the Prentice Postdoctoral Fellowship that facilitated these research projects. I also want to say thank you to the administration, to the university community for providing us excellent support and motivation throughout these years for conducting research at the Prentice Institute. So, thank you very much. Merci beaucoup.
Thank you very much, Kamrul. Unfortunately, I can't see the Q&A, so Jeff Bingley will have to read those questions for Kamrul. But first, I'd just again like to thank you for a very insightful and comparative and methodologically rigorous presentation. There's a lot of data and a lot of stuff going on. That's the technical term. And I really appreciate also the consideration of the policy recommendations. I think this is often one of the challenges for this type of work, is how do we translate our knowledge of these dynamics into meaningful interventions from the micro up to the meso and even the macro levels, in terms of public policy, in terms of curricular design, in terms of social equity, in terms of broader sociocultural practices, et cetera. And they're equally applicable as questions to communities and to populations in Canada as they are to your particular study. So Jeff, do we have any questions for Kamrul?
Not yet, unfortunately. So we're waiting for the Q&A wasn't working. Like I wasn't able to look at it until after the end of the playback there. So
Kamrul, I have a question, and I apologize if maybe you touched on this.
Yes, sure, please.
So it strikes me that the maternal experience within what is termed the perinatal experience is, so there are different functions going on. So you have a question around how many children a woman has had, which may be correlated with wealth or income, right?
Yes.
But then you also have the reality that there's basically a proximity predictor in the form of the likelihood of a facility-based birth influencing the decision for a second or subsequent child to also be born in a facility. So how do we factor in those experiential yet also sociodemographic variables, particularly with a sample size as large as yours?
Well, thank you very much. This is very good question, in the sense that this we have seen that in our study there's higher order births, those who have 3 or more births, they have lower rate of using health facility based delivery. So that means, and also there is another indicator that I should mention here. Those who gave birth in the health facility, the C-section rate is very high, about 75%. Cesarean section. That one is alarming in the sense that we have seen some studies, they found that they mentioned that women, they do not want to go to the health facility because they believe that if they go to the health facility, they will take to the C-section. So the question is why it is so high. One of the reasons is that in private sector, C-section is expensive. They make money out of this. They say that, you have this problem, complications are there, so you need to go to the C-section. So they take women to the C-section, and it's unusually high, 75, it's unbelievable. That is another factor. And yeah, I think socioeconomic factors also. Now, one thing I should mention that in South Asian countries, birth rate was very high in earlier, but recently it's just slightly somewhere between 2 and 3 children per woman, except Afghanistan. They have a very high rate of births per woman, about 5 children. But among the poor women, among the rich women, the rate of birth is not that much different. On average, women are having about 2 children. So, but among them, there are substantial variation by education, by their income, by their occupational status, whether they are giving birth at home or not. Yeah, thank you, Professor Lars, for this question.
Are there any questions from the attendees?
So we have a few questions. The first one from the attendees, and the first one is a follow-up question on the issue of religion. Do you have an interpretation of religions other than Hinduism having a higher rate of home delivery? That is to say, do you think this relates specifically to the religions, culture, identity, and beliefs? Or does membership in these other religions correspond to key variables such as education levels, socioeconomic factors, access to media, or more rural location, and so on?
Well, thank you. This is a very interesting question. Now, the findings that we have here is controlling for education, employment, household wealth, media access, and region. So that means religion has a strong and significant impact on whether women are giving birth at a health facility or not. Now, if I look into compared to Hinduism, those who are the followers of Islam, I can tell about them that the percentage of giving birth at health facility among them is much lower. One of the reason is the perceived religious believe that women, they should not expose to others, if they go to the health facility. Then another problem is that in the health facility, with these countries, they do not have like 100% female doctors for those who want to give birth at a health facility. So that is another challenge that restrict uh, women, particularly those who are followers of Islam. Family pressure comes in here, that they encourage them to give birth at home. This is another reason. Yeah, thank you for these questions.
Another question for Dr. Islam is, first, the comment is very informative presentation and has two questions. One is, can you elaborate on the nature of your data sources? Are there opportunities to draw on qualitative sources such as interviews? And the second question is, maybe we'll let you respond to that one, and then we'll do the second one.
Thank you. I use data from the DSS, Demographic and Health Service, 5 countries, starting from 2004 to 2018. I have pulled data. So the total sample size was 134,881 women. So that is the source of data. Now, the second question is quite interesting, is are there, to that with the one, are there opportunities to draw on qualitative sources such as interviews? Now, this part, when I showed the framework, I showed that there is a arrow, direct arrow from social factors to the health facility delivery. That indicates that there are many other unobserved factors that are not included in this analysis. That things actually tells us that we need to do a qualitative research to get a good sense about the attitude toward the health facility based delivery. What do they believe? Like the question that John asked is, why the rate is very low among Christians, Muslims, and other religions. So I think doing a qualitative study will give us better insight about some other factors that are also playing important role in deciding whether to go health facility or not. Like one important variable that we have from previous qualitative research is the associated cost associated with health facility based delivery, but we do not have this variable in the analysis because I did not have that variable in the data set. Another one is quality of care, poor quality. That is another. So I think this is a very good observation in the sense that if this study is followed by a qualitative study, that will give us a comprehensive understanding, in-depth understanding about what are the other factors that are discouraging women, from going to the health facility based delivery. I can see the second question is, you noted how decisions on health facility based delivery varied by religion. Yes, we already talked about this, but as I said that perceived believe that whether women should go there to the health facility and exposed to others or not, that is also playing important role. But again, we need qualitative research on these areas to uncover the perceived beliefs and attitudes towards health facility based delivery. Thank you, Idion.
I think just as I reflect on these questions, there is an extant literature. It's a little bit dated now on something called informational cascades and the ways in which group or collective dynamics can actually shift decision making over time. And I think there's definitely a space. You can model it quantitatively, but you can also, of course, explore it qualitatively. There are some interesting sort of more, let's call them longitudinal functions that shift that are at play here, which I think it would be a fascinating area to explore either in a very small N study or again, potentially with some of these larger N data that you have accessible.
Yeah, great. Yeah, thank you very much. Thank you.
Okay, I'll just check here again. I apologize, I can't see the Q&A. Are there any more questions from the audience?
I can see this also, so there's no other question.
Okay. Well, I think in the interest of the fact that it's a Friday, it's 1 o'clock and people have given up their lunches. It's a beautiful sunny day today, and we should all be outside and not working this afternoon. We're sitting in front of our computers. Speaking of health more generally and well-being, I'd again like to thank Dr. Islam for joining us today and presenting his research. Informative and fascinating as always. And thank you to those who attended as well for their time and their input and their thoughtful questions. Please do stay tuned and pay attention to the increasing volume of communications coming from Jeff and from the Prentice Institute as we wind up to, let's call it a new academic year starting in the second half of the summer. And I'll thank you all very much for joining us today and wish you a very, very happy, safe, and somewhat socially isolated weekend. Thank you all very much.